My name is Sarah Barnes, and I'm the Director of the Maternal Health Initiative here at the Wilson Center. Today, we are thrilled to be partnering with USAID's flagship Maternal and Child Survival Program to bring you this really important discussion on successful country-led scale-up of reproductive, maternal, newborn, child, and adolescent health interventions. With way over 250 RSVPs for this event, it is clear this topic is very important to a lot of people. We've got an outstanding group of panelists today, with several traveling quite a distance to be with us. So I'd like to give a special thank you to all of you, all of the panelists and the moderators today. As well as a shout out to Charlene Reynolds, Holly O'Hara, and Jen Hogue, and really everyone from MCSP. This is definitely a joint effort, as well as my colleagues at MHI. So just a bit of housekeeping for today. Today's events is organized in two sections. The first section is focused on country-specific cases of scaling up, and the second panel of discussants are focused more on a global perspective. Each section will have its own Q&A session with the audience, so please have your questions ready. For those of you who are in the overflow space, you can write down your questions and then hand them to designated staff in the room. And for those of you who are watching online, you can send your questions on Twitter to #MHDialogue or #ScaleForSuccess, and those are also up on the screen throughout the program. So without further ado, it is my pleasure to introduce Dr. Jim Ricca, who has also been instrumental in the organization of this event. Dr. Ricca is the Learning and Implementation Science Team Lead at MCSP. Over to you, Jim.
Thanks, Sarah. Okay, how do I get my slides going there? Okay, I just want to take a few minutes to lay out a couple of important issues and principles that undergird what we're going to be hearing today about effective scale-up in a variety of contexts. And I'll begin by just emphasizing the fact that our focus today is going to be on the country. That is, the point of view that we're taking is not primarily one of development agencies or innovators. What do countries need to do to reach scale-up? And I'll start by clarifying what we mean first by effective scale-up, and also review features of a country-centered view of scale-up, and I'll end by posing some questions about these features of that scale-up. So I just wanted to also say that to get started here, I wanted to reflect on a paradigm shift that's happened over the last several years, one that's been occurring in global health, and something that authors of a recent Global Health Science and Practice article termed a new world health. Over the last 60 to 80 years, we've seen a steady progression from a situation that is less donor-driven and more country-driven. We can see clearly that resources have increased over the last several years. And more importantly, I want to emphasize that public domestic spending is now by far the largest category of spending for health in low and middle income countries. So we're seeing increasingly self-reliant countries develop national health sector plans solidly grounded on technical evidence and with more control as well over their financing and execution. So the term scale-up is often used quite loosely. This morning we want to be more specific. Countries want to achieve goals in their national health plans, implying the need for widespread and sustained health impact. This is the real goal of the scale-up process, but not all interventions in country plans need to be scaled up. I put a few examples on the right side of this slide of interventions that are already at scale in most countries, but often need improvements in quality or targeting to maximize impact. There's also, I want to point out, some interventions that aren't on this slide at all, and that is because they wouldn't have sufficient evidence of effectiveness to justify being part of routine practice. That's because even if we would scale them up, we wouldn't be sure that they would actually reach impact. But our focus today is going to be on interventions that have already accumulated enough evidence to get a go signal from country decision makers for scale-up efforts, but they're not yet part of routine practice. And I have a few examples on the left side. They're listed separately, but they can be delivered as integrated packages, and usually are. So rough estimates of the collective contribution of interventions in need of scale-up, and I'm not saying only these ones here, but those interventions in need of scale-up when people have done analyses, is that they could contribute anywhere from a third to a half of the entire impact that many countries could achieve by delivering all known high-impact interventions with high utilization. That means that most countries are not going to reach their SDG targets without doing something about a fair number of interventions on that one side of the slide and others like them. So this is an idealized picture of what expansion and utilization looks like over the time, of course, of when a country successfully scales up an intervention. I want to point out a few key features here. First, the length of time that a country spends at the bottom here has to do with processes of a decision to go forward, things like advocacy, the piloting process. We're more concerned today about this part here, the kind of quickly sloping limb of the curve. How can countries make this go up as steeply as possible? But then also, how can they sustain things at the top? If they don't do that, then we would expect things to come right back down. And this can happen with highly donor-driven processes. Another thing I'd like to point out is the timeline on this process. A widely quoted 2011 article said that here in the USA, even in a high-resource environment, that it takes about 17 years on average to go from a bright idea to impact at scale. So, but not, that's an average, and there are certainly others like this one that go very quickly. This is the time course a U.S. pharmaceutical company usually plans for a new and intensively marketed drug. The scale-up is rapid. It depends on a high level of planning, preparation, and resources. But even in high-resource environments, not all rollouts are rapid and smooth. I'm just giving you one example here of HPV vaccine for adolescents to prevent cervical cancer. Or is it to prevent a sexually transmitted disease? So the fact that there was confusion in the messaging might explain the slow rise in this curve. Now let's take a look at a few examples in LMICs. First, oral rehydration salts for child diarrhea. The utilization of ORS has gone up slowly over time. It's even had some periods of stagnation or drops as attention is flagged in some countries. And here's antiretroviral therapy for HIV. It's worth noting that successful implementation of ARVs actually implies a very broad range of activities, trained personnel, laboratory services, mechanisms for long-term follow-up. So it's not easy to scale up, and yet it's had a rapid, relatively rapid rise. And here is a really positive example of pneumococcal vaccine, which rolled out in Tanzania after its launch in 2012. So these and other examples show that there's been a broad range of success, both in high and low resource environments, and they illustrate some things we've learned about the scale-up process. Sometimes the difference can be attributed to the nature of the intervention. Simpler is generally easier. Sometimes there's a clear difference, influence of strong outside support, and ARVs is certainly one of them, but it's also a tribute, in this case, to the importance of financing. And other interventions have been hampered by a lack of supportive policies. This has been the case in some countries with antibiotic treatment for children with pneumonia by community health workers. So what do we know about successful scale-up? First, the scale-up process will likely take place over years in a complex and not completely predictable environment where critical features of the landscape might change, like the political or economic situation. This has several implications. The scale-up of health interventions needs to be an actively managed process to be efficient and effective. So first, the team needs a plan. And they will also need reliable and actionable information to determine how well the scale-up process is working and when inevitable and often unpredictable problems occur. They'll need to have this information not when the next DHS survey occurs or even next year. And they'll need resources over a period of time that extends beyond the life of any one project unless they want to stall out before they reach the summit. So I'd like to put all this together from the point of view of a country desiring to scale up high-impact interventions, either alone or in packages. So if a decision's been made in the health sector plan to go forward and scale something up, this means that there's enough evidence out there, there are clear policies, there should be, that support its implementation, and that there's some initial financing, whether that's from international, domestic, or a combination of sources. The goal of the process will be to significantly contribute to national health targets by achieving widespread and sustained impact. In order for this impact to be, to reach impact, there needs to be high effective coverage. That's utilization by those that need the intervention. And in order for the gains to be sustained, the key supports must be institutionalized. If they are to be delivered through the private sector, institutionalization of markets, through the public sector and public sector institutions. So here we see the engine of the scale-up process. We need to take account of implementers as well as leaders and managers. They need resources, as we've said. they need sufficient and timely information, but they also need some sort of way to feed this back for continuing learning and adaptation. I want to point out a few features here just to close. 4 critical areas. First, planning. In a complex environment scale up, planning must be system-oriented but allow for adaptation. So a couple key issues here. What we like to call a scalable model sometimes. No one likes pilots anymore, but we do need to develop a model that works in the system at a point close to service delivery, but with all the needed supporting elements that are present. And that's usually the district. There needs to be micro-planning and not just large strategic plans. Managers need to make adaptations. And in order for all these things to work, a phased rollout of some kind is almost inevitable. Second, people and partnerships, both leaders and implementers. Who needs to be involved in the process? What leadership, management, and partnership structures are needed and feasible at local, subnational, as well as national levels? And how are issues of authority and accountability effectively handled in a multi-partner coalition without line authority a lot of times? And next, information use and adaptation. To negotiate successfully in a complex environment, actionable information is needed, and it's needed frequently. So is there interest, capacity, and incentive to use information? Is there openness to bad news when things aren't going well? And these questions need to be asked not only of implementers, but also of technical agencies and donors. Because the most important information is likely that we're likely to get also is the most important information, I should say, that we want to get is actually utilization, but that's very hard to come by. And so sometimes we also make what I think are one of 2 bad decisions. We either do what I call driving blind, that is we don't have any data, or we make inadequate measures like number of people trained or geographic availability of the service, the main thing that we follow. And this leaves us in a situation like the drunk person looking for their keys under a spotlight. We ask them, are your keys here? And they say no, but this is where the light is, so I'm going to keep looking here. And in closing, just one last issue of financing. I think there's some key issues here, again, because financing has to exist over an extended period of time. What are novel financing strategies that can drive successful scale up? So I'll leave it there as far as laying out some key issues for our panelists that they'll explore later on. And I'll hand it over to Nefra Faltis from USAID, who will moderate our first panel of country representatives.
Thank you, Jim. We're very fortunate to have with us today this group of experts and champions to share their firsthand country experiences driving the scale-up of high-impact reproductive, maternal, newborn, and child health interventions. In a moment, we're going to learn about the Democratic Republic of Congo's rich history implementing and nationally scaling up integrated community case management, or ICCM, for childhood illness, using chlorhexidine in Nigeria to help newborns survive during those first critical moments of life, and the combined forces of building capacity for postpartum family planning alongside immediate newborn care in Rwanda. And I think you'll find that some of the themes common to all of these scale-up experiences include the need to tackle critical health systems barriers and leveraging broad-based partnerships fueled by country leadership in order to succeed. We'll hear from each of these country panelists, and then we'll save some time at the end for questions. Let's turn now to our first group of panelists from the DRC, and starting with the child. Presenting on behalf of the DRC, it's my honor to introduce to you Dr. Jean-Fidèle Ilunga Mumbai, National Coordinator for Integrated Management of Neonatal and Child Illness, or RMNCAH, with the Federal Ministry of Health. Joining Dr. Ilunga is Dr. Jimmy Anzola Mangora, Provincial Program Team Lead for Chopo and Bazuele provinces for the USAID-supported Maternal and Child Survival Program, or MCSP. And providing translation support, we have Dr. Serge Raharisan, Senior Technical Advisor for Child Health, also with MCSP. Dr. Ilunga, je vous donne la parole.
Bonjour, mesdames et messieurs. Je vais vous présenter l'expérience de la République démocratique du Congo en termes de la mise à échelle des sites de soins communautaires.
Good morning, ladies and gentlemen. I will present you the experience from the Democratic Republic of Congo on scaling up community care management.
Et comme vous pouvez le voir, 4 points essentiels. Pourquoi les sites de soins communautaires en RDC? Quels en sont les résultats? Quelles sont les stratégies de mise à échelle? Et quelles sont les opportunités et les défis que nous avons pour le moment?
I will cover 4 points: justification of community case management, results, strategies, opportunities, and challenges.
Nous allons voir là la trajectoire de la mortalité de moins de 5 ans en République démocratique du Congo. Beaucoup de choses ont été faites jusqu'en 2015, mais il reste encore beaucoup de défis pour que la République démocratique du Congo puisse accélérer les taux de réduction annuels, maintenir le cap et atteindre les objectifs de développement du millénaire d'ici 2030.
Our efforts have resulted in significant reduction of under 5 mortality rate by the year 2015, but the DRC has to dramatically accelerate its annual reduction rate, keep the momentum, and take more aggressive approaches in order to meet the 2030 Sustainable Development Goals.
La carte que vous voyez montre dans les couleurs rouges les 14 provinces qui ont la forte mortalité de moins de 5 ans dans mon pays. Et donc, nous savons où est-ce que nous pouvons agir dans notre pays.
The map on the screen shows in red background the 14 provinces with high mortality. Therefore, we know where to take action.
Les sites de soins communautaires répondent ainsi à l'insuffisance de la couverture sanitaire de mon pays qui est totalement à 30%. Il s'agit d'une aire géographique couvrant la population d'environ 1000 habitants. Et dans chaque site de soins communautaires, un relais assure un paquet de services suivants. La prise en charge des cas simples de paludisme, de diarrhée, de pneumonie et de la malnutrition. Il ou elle réfère le cas grave, fait des activités de communication pour les changements de comportement et assure la surveillance à base communautaire des effets indésirables de médicaments.
Therefore, the community care sites respond to the needs in coverage of health services in my country, which is only 30%. It's a geographical area covering approximately 1,000 inhabitants, and in each site, the community relay offers the following package of service: management of simple cases of malaria, diarrhea, pneumonia, and malnutrition. He or she refers the severe cases, perform behavior change communication activities, and community-based surveillance of secondary effects of drugs.
Comme vous pouvez le voir, les sites de soins communautaires ont été intégrés dans mon pays en 2005 et depuis lors, beaucoup des ajustements ont été réalisés jusqu'à l'élaboration d'un plan stratégique actuellement.
The DRC adopted the community care sites in 2005, and since then, many adjustments were undertaken as presented on the screen and until the development of the National Strategic Plan of RMNCAH.
En 12 ans, c'est-à-dire entre 2005 et 2017, nous avons formé près de 14 000 relais communautaires et avons dépassé la couverture de 10 millions de personnes couvertes par les sites de soins communautaires.
In 12 years, between 2005 and 2017, we trained almost 14,000 relays and exceeded 10 million population covered.
Avec l'appui de nos partenaires, nous avons couvert les 26 provinces de la République démocratique du Congo en site de soins communautaires. Cependant, seulement 12 provinces qui ont le fond vert sur la carte ont une couverture de plus de 80% en site de soins communautaires dans leurs zones de santé respectives. C'est encore moins de 50% de nos 26 provinces.
With support from our partners, we have covered all 26 provinces of the DRC in community care sites. However, only 12 provinces with dark green background on the screen implement the complete package in at least 80% of their respective health zones. That is less than half of the 26 provinces of the DRC.
La contribution de nos partenaires en santé de l'enfant sont complémentaires et synergiques. Certains appuient les formations et les supervisions, d'autres encore appuient l'approvisionnement en médicaments et intrants, et d'autres appuient les programmes de soutien comme le renforcement basé sur les performances.
The contributions of our partners to the child health program are complementary and synergetic. Some provide support to training and supervision, others help with procurement of drugs and commodities, and others implement supporting programs such as result-based financing.
Mesdames et messieurs, maintenant, je vais vous présenter les grandes lignes de stratégie que nous avons mises en place pour maintenir de façon systématique le support vers le passage à l'échelle.
Ladies and gentlemen, now I am going to present some highlights of the strategies that we are currently implementing in a systematic way to support scale-up.
En matière de gouvernance, une unité de coordination nationale peut s'y mener, comprenant tous les départements techniques impliqués dans la santé de l'enfant et le partenaire du gouvernement qui sont sur l'écran mènent l'agenda de programme de santé de l'enfant en République démocratique du Congo.
In terms of governance, a national coordination unit for RMNCAH involving all of the technical departments involved in child health and partners of the government presented on the screen leads the agenda of child health program in the DRC.
L'année dernière, nous avons élaboré un plan stratégique national de Pessimeni pour la période de 2017 à 2021. Et en plus, nous sommes en train de finaliser le plan stratégique de santé communautaire. La prise en charge communautaire est totalement couverte par ces deux plans, avec la projection de mise en place de 8000 sites de soins communautaires supplémentaires pour couvrir 70% des besoins de mon pays.
Last year, we developed an RMNCAH National Strategic Plan for 2017-2021. In addition, we currently are finalizing a National Community Health Strategic Plan. ICCM is completely covered in these two plans, with the intent to implement 8,000 additional sites to cover 70% of the country's need.
En matière d'information, les informations clés de la prise en charge communautaire ont été intégrées dans le système d'IHS2 national depuis la mise en œuvre du premier système en 2014. À la suite de l'atelier régional en Afrique du Sud sur l'amélioration des données de routine dans les systèmes nationaux d'information sur la santé de l'enfant, nous avons mis à point un plan de redressement. Actuellement, une base de données Pessimeni et un portail web sont en cours de développement.
In terms of information, key data on integrated case management has been integrated into the national DHIS2 since the implementation of the first system in 2014. Following the regional workshop on improving routine data for child health in National Health Information System that happened in South Africa in 2017, we developed an adjustment plan. Currently, an RMNCAH database and a web portal are under development.
En matière de financement, le cadre d'investissement de la RDC pour le mécanisme de financement global illustre la coordination de la mobilisation des ressources en République démocratique du Congo. Le processus a impliqué les techniciens du bureau du Premier ministre et de 4 ministères, à savoir la santé, les finances, le plan et l'intérieur, ainsi que la Banque mondiale et le membre de la coordination de la Pessimeni.
In terms of financing, the development of DRC's Global Financing Facility, GFF, investment case illustrates the resource mobilization coordination in the DRC. The process involved officials from the Prime Minister's office and 4 ministries, Health, Finance, Planning, and Interior, as well as the World Bank and the members of the RMNCAH coordination.
Le cadre d'investissement approuvé couvre 14 provinces ayant les indicateurs de santé et socio-économiques les plus bas. Et cela, ils ont une couverture de 2,6 milliards de dollars américains. La répartition du budget présentée sur l'écran montre la complémentarité de plusieurs ressources de financement. Pour la toute première fois, le budget national du gouvernement congolais comporte une ligne spécifique dédiée à l'amélioration de la santé de la mère et de l'enfant.
The approved investment case covers 14 provinces with the poorest health and socioeconomic indicators, with a proposed budget of more than $2.6 billion US. The distribution of the budget presented on the screen shows the complementarity of multiple sources of funding. For the very first time, the national budget of the Congolese government has a specific line dedicated to support maternal and child health.
En matière d'offres de services, l'équipe du ministère de la Santé publique et de partenaires s'est servi de l'outil liste pour identifier les interventions les plus porteuses afin de prioriser le rôle des relais communautaires. L'analyse spécifique des données de la RDC présentées sur l'écran ont été récemment utilisées pour informer le développement du plan stratégique de la santé communautaire.
In terms of service delivery, the team of the Ministry of Public Health and partners used the LIST tool to identify the most relevant interventions and prioritize the roles of the community relays. The analysis from DRC-specific data presented on the screen were recently used to inform the design of the strategic plan for community health.
L'intégration de la PCME dans son approche globale produit des résultats très encourageants. À titre d'exemple, avec l'appui de MCSP, intégrant le paquet complet PCME et prise en charge communautaire dans 2 provinces, la Chopo et le Bawele, nous avons obtenu une augmentation de plus de 4 fois le nombre de cas de pneumonie et de diarrhée traités au niveau de 106 centres de santé appuyés et de plus de 9 fois le nombre de cas traités dans 119 sites de soins communautaires.
The integration of RMNCAH in a comprehensive approach produces encouraging results. As an example, with support from MCSP, integrating a full package of RMNCAH and a CCM in 2 provinces, we achieved over 4 times more cases of child pneumonia and diarrhea treated in 106 supported health facilities, and over 9 times more cases treated in 119 community care sites.
Mesdames et messieurs, en résumé, nous sommes maintenant très contents et fiers de tout ce que nous avons accompli jusqu'à maintenant. La volonté politique de notre gouvernement et l'engagement de nos partenaires nous ont permis d'étendre le programme de prise en charge communautaire dans toutes les 26 provinces du territoire national. Nous pouvons maintenant utiliser des fonds du paludisme Fonds mondial, du PMI et de DFID pour la prise en charge communautaire et les efforts de plaidoyer auprès d'autres partenaires sont en cours. Les fonds de GFF sont maintenant disponibles pour soutenir les 14 provinces ayant des indicateurs les plus bas.
Ladies and gentlemen, in summary, we are happy and very proud of what we have achieved so far. Our government demonstrates a high-level commitment and is supported by committed partners within one unique coordination mechanism. We managed to expand the CCM program in all 26 provinces of the country. Finally, the community data are collected in an integrated national health information system. We can now use malaria program funds from the Global Fund, PMI and DFID to support ICCM. Advocacy efforts with other partners are ongoing, and funding from the GFF are now available to support 14 provinces with the weakest indicators.
Également, nous sommes en train de faire la revue à mi-parcours de notre plan national de développement sanitaire et nous allons nous focaliser plus sur la santé de l'enfant et de l'adolescent dans les jours qui suivent.
In addition, we are in the midst of the midterm review of our National Health Development Plan, and we are going to put more emphasis on maternal, child, and adolescent health in the coming years.
Cependant, d'importants défis nous restent encore à relever. Il s'agit des difficultés logistiques inhérentes à la taille du pays et à sa population, des difficultés d'accès géographique, l'insécurité, la survenue des épidémies comme l'infection à Ebola actuellement, le choléra et autres qui détournent constamment l'attention et les ressources. La survenue des questions qui sont inhérentes également à la pérennisation à la fragmentation de l'assistance technique et finalement la rupture d'utilisation des données pour prise de décision à la base qui n'est pas encore acquise.
However, important challenges remain, including logistical difficulties inherent to the size of the country and its population, challenges to geographical accessibility, insecurity, epidemics such as Ebola virus infection, cholera, and others that constantly distract the attention and resources. Questions around sustainability, fragmentation of technical assistance, and finally, the culture of use of data for decision-making at the front line that is not acquired yet.
Pour terminer, mesdames et messieurs, qu'il me soit permis de transmettre au gouvernement américain et à son peuple le remerciement le plus sincère de mon pays pour l'appui significatif que nous bénéficions de l'USAID et plus spécifiquement ici à travers le projet MCSP.
Ladies and gentlemen, please allow me to express the sincerest gratitude to the government of the United States and its people for the significant support we receive through USAID, and more specifically here through the MCSP project.
And now, can you please me remember this day and repeat with me, every child is my child. Can you use this? And again, every child is my child. Thank you very much.
Merci, Dr. Ilunga, and thank you for that elegant closing note and rallying cry. We're now going to take you east to Rwanda and turning now to mom and baby. I'm very pleased to introduce to you now Dr. Jacqueline Omunyana, Senior Learning and Scale-Up Advisor for MCSP, presenting on behalf of our Rwanda panel. Joining Dr. Omunyana is Madame Catherine Mugeni, Director of Community Health with the Rwanda Biomedical Center's Maternal, Child, and Community Health Division. Dr. Omunyana, you have the floor, as they say.
Thank you. Good morning, ladies and gentlemen. Hello, can you hear me? Oh, great. Okay. So I'm pleased to share with you Rwanda's experience on scaling up PPFP, that is postpartum family planning, and practice improvement for labor management and immediate newborn care. So why did we choose to scale up PPFP and newborn care interventions? It is because there was maternal death or neonatal death, they were still high compared to other infant or under 5 mortality, and birth asphyxia was one of the leading cause for birth asphyxia was the leading cause of neonatal mortality. So for PPFP, I'll be changing because it's 2 interventions, and please bear with me when I talk about ENC, HBB, and then PPFP. So there was previous experience on scaling up HBB interventions, and since 2010 until 2013, there was strategies that were put in place to reduce death due to birth asphyxia. But with all these strategies, newborn death due to birth asphyxia was still the leading cause, and we built on these existing strategies, but what we added was to look at the mother and the baby, because there's no way you can separate a mother and the baby. So for PPFP, globally we know there's a 65% of unmet need for family planning, and indeed in Rwanda 19% of married women have unmet need for family planning, and one of the leading unmet needs it is in the postpartum period. So that is why Rwanda committed to scale up PPFP intervention, especially in the immediate postpartum. That is the golden opportunity. We do not want to miss that opportunity. So what kind of interventions are we talking about, the package? Remember, Rwanda had previous experiences or strategies that were put in place to reduce neonatal death due to birth asphyxia. But together with the government of Rwanda through USAID support, we came up with a strategy that aimed at retaining skills of providers that were trained. So this, for PPFP, it was more of training providers on PPFP counseling and also clinical skills. This was also followed by mentorship. These interventions were rolled out in a phased manner, built on whole system building blocks, starting with 4 districts. In Scale Up, there's different, you learn and then you adapt accordingly. So we started in 4 districts, then we add, depending on what we learned in 4 districts and lessons, it guided our implementations in additional districts. So in Rwanda, MCSP through USAID support, we support 10 districts out of 30 districts, which is more than 30% of the coverage. So the way we roll out these interventions, we work with existing systems. So we work with technical working groups, so that they mostly they're chaired by the Minister of Health, and they provide technical guidance and other advocacy interventions. So how do we measure these interventions? Or it's through existing systems. In Rwanda, we do have a robust national health management information system. But in order to have a very good monitoring of these interventions, we also advocate to have a dashboard so that we keep tracking of what is working or what is not working in terms of data. So I want to share our progress so far for the 2 years so far. We're happy to share with you that since 2005 until 2017, 45% of women in postpartum period, immediate postpartum period, which is 48 hours, were able to be discharged with a method. Out of these 45%, 30% were discharged with a long-term acting, reversible acting method. And we're also happy to share with you that our aim, it is of reducing birth asphyxia. We are on a red track, because since 2015 until 2017, birth asphyxia has been had a steady decrease, especially in the 10 MCSP districts. These are HMIS. These are HMIS data, and it is also in line with the maternal neonatal death audit, which shows that birth asphyxia is no longer the leading cause of birth asphyxia. I mean, of neonatal death. So, in order to talk about scale up, you need to cost the interventions. Otherwise, it would be hard to be able to say that you're really scaling up. So, these interventions, they suggest that they're relatively low cost with potential high impact. At a national scale, the cost of these interventions represent less than 1% of the current government spending on health. So we are happy also to share with you that most of these interventions are institutionalized, and we included PPFP indicators in the national HMIS. These interventions are also included in the district health strategic plan. That means the district can be able to have their budget allocated for the interventions and be able to conduct their trainings and be able to do the mentorship like the way I mentioned. So this is just a simple illustration on how we started in 4 districts, but after learning that these interventions really work, we added to the entire district. So far, more than 20% of the districts are implementing PPFP services. And this is our state minister, and I think others, you can really recognize them. Okay. So with Scale Up, you need to identify some of the critical actions that can be able to sustain your actions. And one of the things that we worked on was to collaborate with other partners through technical working groups. and using dashboards to monitor the progress and identify leaders and managers at multiple levels, and also having a flexible planning process so that you can learn as you adapt. So I would like to extend our appreciation to USAID's support through Maternal and Child Survival Program. This is Scale Up. The journey continues. There's no falling back. Thank you very much.
Thank you, Dr. Munyana. Last but not least, we're going to take that mom and baby back out west, this time to Nigeria. Now, let me tell you just how not least this work that we're about to hear about is. It builds on efforts dating back to early 2013, when the Nigerian government in Sokoto State launched procurement of chlorhexidine for newborn survival. And that made this state the first government in Africa to launch the use of chlorhexidine. First government in Africa. So with that teaser, I'm now happy to welcome our two final country panelists and presenters from Nigeria. Dr. Abosede Adeniran, Director of the Child Health Division with the Family Health Department in the Federal Ministry of Health, and Dr. Olayenka Omar Farouk, Senior Newborn Health Specialist with MCSP and Scale Up Uptake Coordinator for the Federal Ministry of Health.
Good morning. I'm here to present the experience of Nigeria on the journey to scaling up chlorhexidine nationally. As the National Demographic Health Survey has shown that the newborn mortality has not really changed in the last 15 years. It has remained static, while the infant mortality rate and the other 5 mortality rates are actually declined between 2008 and 2013. This is the infant mortality rate. It has remained stagnant. And what are the key causes of neonatal mortality rates in Nigeria? The key causes are preterm complications, intrapartum complications like bacteriosphasia, closely followed by sepsis. And in Nigeria, we know our caregivers, they do use harmful traditional practices for cord care. So that has been the source of infection that has been contributing to the prevalence of sepsis that we have. So following the recommendation of WHO in 2015, that countries with neonatal mortality rate above 30 per 1,000 live births, with high home births in Nigeria, about 63% of the births took place outside the health facility. And with the use of these harmful traditional practices, the government of Nigeria took the initiative that we need to adopt the use of chlorhexidine for cord care management in order to prevent sepsis. Following this, the process commenced with the pilot study in Sokoto and Bauchi states, so as to be able to generate the local evidence, because we have the global one, but we need to generate the local evidence based on context. And by 2015, we've been able to integrate chlorhexidine into the training packages of healthcare frontline health workers. And also by 2016, we've been able to develop the national strategy on scale-up of chlorhexidine with support from USAID. We are scaling up chlorhexidine gel for cord care to prevent sepsis. Who is scaling up the chlorhexidine? As we are all aware, Nigeria runs a decentralized system. We have 3 levels of healthcare: the federal level, the state level, and the local government level. And each level has the roles and responsibility in the implementation of healthcare service delivery. The role of the federal government is to provide the policy environment, strategic direction, while the actual implementation is at the state level as well as the local government level. How are we scaling up this intervention, we have developed a costed strategy with 5 critical components addressing the issue of demand creation, supply and logistics management, advocacy, financing and coordination, and monitoring and evaluation in order to track the progress. And the scale-up strategy is being implemented in an integrated approach. We are leveraging on existing structure. Based on this, we've been able to incorporate cloexidine into all relevant maternal, newborn, and child health documents in Nigeria. And this includes the Nigeria Every Newborn Action Plan that was launched by the Honorable Minister also in 2016, the Essential Newborn Care Cost Package that we now train our frontline health workers on, and the Essential Medicine List, because the cloexidine needs to be included in the Essential Medicine List before it can be procured at the various levels of government. As I've said earlier, we operate a decentralized system. And for us, we've realized partnership and coordination are key in scaling up any intervention to the national level. Based on this, the team of resources that is driving the process for scale-up in Nigeria is being led by the Honorable Minister of Health himself. That's the Honorable Minister of Health at the launch of the national strategy on cloexidine, as well as the NENAP on November 16, 2016 in Abuja. And in addition to the partnership also include working closely with the state government. As I say, it's decentralized. Whatever is done at the federal level is generic. The states are expected now to develop their own plans based on the context and for them to now implement with it. So we have worked closely with the state. In addition to that, we also work with the professional bodies, because the professional bodies also need to orientate their members in order to be able to utilize cloexidine for cord care. And most importantly, the good ally we also have in Nigeria is the private sector, the pharmaceutical company. Currently in country, we have 4 pharmaceutical companies that are producing cloexidine, and they've been able to donate these commodities to the state level and even during international conferences of the professional body.
So simply put, scaling up in a decentralized environment means one cap does not fit all. In planning your strategies and approach to scale up at in a decentralized level and at subnational level, you need to put some principles into context. One, you need to understand your scale-up environment. You need to understand the health priorities of that state. You need to understand the political structure. You need to understand the health system, and most importantly, the sociocultural context in which the intervention you're scaling up is applicable. I'll be sharing the experience of Kogi State, one of MCSP supported states, in scaling up cloexidine use. Key to this is a political will. With advocacy, we're able to establish political will within the state. Subsequently, engagement of key stakeholders resulted in translating the national strategy into an operational plan in line with the vision of 90% coverage by the year 2022, focusing on 5 key principles as outlined on the slide. I'll be talking more around measurement. The state intends to track progress of implementation through measurement. Unfortunately, we do not currently have a system in place in country to track the use of cloexidine at birth. And as such, in line with the principles of integration, we needed to look at what was existing within the system. So Kogi State sought national approval to use existing system, the labor and delivery register, and create a column. We needed to innovate to track the use of cloexidine in the labor and delivery register, and subsequently report on the monthly summary form, which feeds into the national DHIS, the District Health Information System. And within 2 years, we've seen a steady rise in the application of cloexidine at birth versus live birth. In the last 6 months, we've been recording about 99% of newborns having cloexidine applied at birth. And how did we do this? We followed the principles of scale-up as well as just connecting the dots between the different components of scale-up that is within the state operational plan.
In conclusion, just to highlight key components, that since the process commenced in 2015, we'll be able to make some remarkable progress. With the federal government providing the strategic direction, the states have been able to develop their own state plans, 37 of them. They've developed their state plans, and they've integrated it into the state health strategic plan. In addition to that, we've received some political will. About 19 states have been able to use the state government funds to procure some chlorhexidine for implementation. In addition to that, some of the states, about 31 of them, have also commenced sensitization activities to create awareness. What are the key things that have been responsible for this success? For us, the local evidence from Sokoto and Bauchi provided the evidence for us to scale up. And we did not want to lose that momentum. We wanted to sustain the gains from Bauchi and Sokoto State. And based on this, with government providing the leadership and partnership with the professional bodies and other stakeholders, the government of Nigeria will be able to develop the strategy, and this strategy has been translated into state plan action, which is currently being implemented at the state level. So for us in Nigeria, the scale-up has been a successful learning curve for us. We started with a pilot, 2 states, in 2012. Today, 2018, we are scaled up to 24 states that has been able to develop their plants and also procure commodities. However, there are challenges. And in going forward, we plan to address these challenges in order for us to be able to actualize the goal of the strategy that we set out. That's by the 5th year of implementation of the strategy, we should have increased the uptake of chlorhexidine use to 52%. Thank you for listening. Wish I could phone paper this time.
I couldn't possibly compete with those adorable babies. But just to thank you, and Drs. Adeniran and Olayinka, and to the rest of our panelists for those rich presentations. Now, I'm sure many of you are eager to ask our panelists some questions. Maybe while you're collecting your thoughts, perhaps I'll share some initial questions and reflections to start us off. I'm going to start maybe by borrowing Dr. Olayinka's expression around connecting the dots. In this case, connecting the dots between supply and demand. And when we think about what doesn't work in scale up, we sometimes see a lot of focus on the supply side, but without sufficient attention to the demand side. And when we talk about demand, this could refer to anything from strengthening political will at national or subnational level to perhaps influencing provider practices, or maybe it means increasing community awareness and demand for services, for example. But there often seems to be a sort of chicken and egg interplay between supply and demand, where on the one hand, perhaps scale up is helping to drive improved availability of services, but then maybe on the other hand, local manufacturers or wholesalers aren't seeing this high market demand yet, and in turn, maybe neither providers nor clients are seeing that service as the norm yet. So my question then for our panelists is, have you seen really addressing this demand side as having its own particular challenges? If so, how do you break this cycle to drive higher utilization of the intervention that you're first trying to take to scale and then maintain at scale? Maybe I'll start by addressing this question to our Rwanda colleagues.
Thank you. I think As you know, Rwanda have a big commitment to reduce the maternal child mortality, and we see that even if we have many interventions, for example, at health facilities, there is many intervention on ANC, PNC, HBB. There is also some intervention, HIV, nutrition. We have also many clients, since Rwanda have more than 80 people who have insurance, mutuelle de santé. Most of them go to the health facilities to take service. All of these intervention Rwanda put in place to have a universal coverage challenge also the health providers. We see this gap between supply and demand. For example, in the health facilities, when clients come to demand the family planning products, the health provider don't take enough time to explain them to the counseling what is the side effect, what is difference between the long-term or short-term methods, because of the few number of health providers at health center. And which is good to have many interventions, but we need also to balance the ratio between the client and the health workers. Rwanda still work on it, on HRH, but with MCSP, at least we've started this capacity building for those health workers we have at health facility and hospital through the capacity building approach, to the low dose and high frequency, which approach is very good to continue to do the mentorship. And they really appreciate, because when they go to the health facility after the training, they come back, let's say 1 week after, to exchange with other health providers and with mentors on what they see on the field. We think today we need to continue to strengthening the capacity of the health workers at health facilities. And there is also another issue, the turnover of health workers. Reason why we need to have a strong plan of training, continue to train them through the this approach. And I think we can, one of the day, give a quality service at health facilities. Thank you.
Thank you very much. I think you're certainly touching on some key health systems issues that impact provider-driven demand. Perhaps the same question for Dr. Ilunga from DRC.
Merci beaucoup. C'est une question qui est générale, même dans notre pays également.
This question applies to our country as well.
Mais elle dépend beaucoup du système de communication.
But it really depends on how do you do communication.
Nous avons trouvé que la communication est confisquée par les médicaux.
So now we find that communication is now confiscated by medical professionals.
Je pense que dans notre domaine, il faut décentraliser et responsabiliser ceux qui ont la communication, qui doivent faire cette communication concrètement et réellement.
So we need to make sure that those who in the real world are doing the communication are really empowered to do the communication.
En prenant l'exemple de la chlorhexidine dans mon pays, nous avons trouvé également des stocks de chlorhexidine non utilisés parce que les personnes ne savaient pas pourquoi on avait amené ces chlorhexidines là-bas.
For example, in my country as well, we found expired chlorhexidine that were not utilized because people didn't know what to do with them.
Nous étions obligés de faire des petites directives rapidement pour montrer l'utilisation correcte de la chlorhexidine partout où ça se trouve.
So wherever we have chlorhexidine available, we made very quick recommendations and directions to the providers on how to use them.
Donc tout ce qui est nouveau, il faut toujours d'abord la communication et puis on apporte le service.
So for everything that is new and innovative, we really need to focus on communication first, and then we implement the program.
En ce qui concerne les sites de soins communautaires, nous commençons par sensibiliser la communauté sur l'implémentation de la site dans leur communauté.
For example, for the community care sites and ICCM, we first sensitize the communities, and that's the very first step.
Donc nous ne pouvons pas implanter un site sans avoir sensibilisé cette communauté.
So we cannot set up a site without sensitization, proper sensitization of the community.
Pour obtenir l'appropriation et l'implication directe même des chefs de village et des responsables coutumiers.
That is building ownership and engagement at the very local level, including the chief of villages and the local communities.
Et la deuxième chose, c'est que nous avons deux types de relais communautaires, le relais promotionnel et le relais prestataire qui travaillent dans les sites de soins communautaires.
And in addition, we have two types of community relays. The first category is the relay providers, and category number 2 is the promotional relays in charge of communication.
Et le relais communautaire a aussi comme tâche de sensibiliser le ménage sur l'utilisation du site de soins communautaires.
So both relays have the roles of doing the communication with the families and households.
Et donc pour moi, la clé, c'est la communication qui est souvent très confisquée, qui n'est pas libéralisée pour que les acteurs de la communication puissent aider le système à apporter les techniques qu'il faut et la manière qu'il faut pour la communication.
So the problem is that we tend to take the communication from ourselves and do not really empower the people who should do it.
Quand nous changerons, nous avancerons mieux.
When we ourselves will make change, then we will be able to move forward.
Merci.
Thank you. An important reminder that availability does not necessarily translate into utilization, but also on the potential for communication, I think, to help bridge that gap. Maybe one more question before we open it up to the broader audience. I think as we've learned from, let's say, the patchwork map of the DRC and the unique experiences in Kogi State in Nigeria, that context can really differ greatly, not only across countries, but even within a country. And one region, for example, might be vulnerable to shocks and stresses, like disease outbreak or conflict, than another, for example. Could you share with us perhaps one example of a shock or a stress that these scale-up experiences have faced? And if so, what did you have to do differently to adjust what you might have called your model for scale-up? Did you have to use resources any differently? Perhaps I'll start maybe from the implementing partners perspective with Dr. Olayinka from Nigeria.
Thank you very much, Nefra. So I think I'll follow in your line of around resource mobilization. So in 2016 was when the strategy, Clear City National Strategy was launched, but prior to then, there was a lot of work to develop the strategy. And in developing the strategy, we tried to look at what was the resources available in terms of newborn health space, maternal, newborn, and child health, and more leveraging around the partner support. And so in developing the strategy and looking at a phased approach, we recommended a phased approach looking at 16 states around those with the highest newborn mortality, as well as those with supporting partners. But following the launch of the strategy, and it was now time for implementation, all the partners that were identified in those 16 states were no longer available. And there was a need to re-strategize on what we're going to do. Along the line came a World Bank fund to states. And we also realized that really the phased out approach shouldn't happen at national level, but rather at state level. So rather than calling together 16 states alone, we met and disseminated to all 37 states, or 36 states and the FCT, and left the phased out approach to the state level because that is where the real implementation would take place. In looking at probably stress again, so you're now at the level of the subnational level, and you've been able to advocate and you've been able to get the government to buy the product. So sitting down and looking at different funding sources. So Kogi State has about 30,000 tubes of chlorhexidine bought, and the shock is about 17,000 are still within the stores. And you have about 127 deliveries on an annual basis. So even the product that was bought is not enough, but a year down the line, half of the products are still within the stores. So there's the issue around distribution. How does the product get to the last mile? And we've already talked around the issue around awareness. So you have a training package that is just for health workers, and you expect mothers to be able to apply chlorhexidine, and you've not addressed the demand side. So which is one of the challenges with having an integrated system, because everything does not move at the same pace. So you have your strategy there, your communication strategy is not ready, your HMIS to register, to track your progress of implementation is not ready. So that's it.
Thank you, Dole. Thank you. Maybe I'll ask the same question of our DRC colleague, Dr. Nzolo.
Thank you. We had an experience of Ebola in Akete Health Zone last year, so that all monthly supervision of nurses to the community car seats were postponed. And a reported joint supervision with MCSP and HERMOI was postponed and transformed to a technical assistance to the DPS of Bazuili. And another element is that the TDR, the test of malaria, was prohibited to avoid blood. Another element is that we had to allocate a few of our funds to other things, so that you had to reinforce wash precaution in the community car seat in Aketi, and to strengthen the awareness in the community by relais promotional relay. Thank you.
Thank you, Dr. Nzolo. I think a lot of lessons to be learned there, including that it seems that sometimes in the process of scaling up, really to do so effectively and to be nimble in fragile contexts, that sometimes that means even having to put that scale-up effort on hold to first do no harm.
Yeah.
Let's now take some questions from the broader audience for our country panelists around the room, in our overflow room, and from online. If you would like to address a question to our panelists, we would ask 4 things of you. Are you ready? First, we ask that your questions actually be questions and not statements. But we appreciate your passion nonetheless. Feel free to email the panelists afterwards. Second, please try to make your questions as succinct as possible. You might not be looking at that glaring clock in the back, but we are, and we're already over time. So we want to maximize the number of questions we can field from all of you. Third, please introduce yourself before you ask your questions. And fourth, please specify which country panelist or panelists your question is for. So let's start maybe with a question from the room. Yes, in the center back.
Hello, good morning. My name is Ekmayong Ekanem. I work with Apt Associates. I'm directing my question directly to Dr. Adediran, and Dr. Olayinka can chime in. It has to do with the logistics of chlorhexidine. I mean, it's a simple intervention. It saves lives with respect to sepsis in the postpartum period. But how is this? How is the logistics working with respect to the sustainability of it post the MCSP program? You know, and that scale-up process in some of the states that were not exemplified, like Kogi State or Sokoto State.
Thank you very much for your question. When we were developing the strategy, we took cognizance of decentralization. As I said, it's state-level implementation. And what is currently being implemented with logistics is the integrated approach That is the problem we have in Nigeria, and it's taking things back. So currently we are implementing the integrated maternal, newborn, and child health logistics management system. And it's at the state level, anchored by the Department of Pharmaceutical Services. So because we are talking about drugs and medications. So but the challenge we have is that the time products are being moved out is not as when the chlorhexidine is also going out. So that's the challenge we're having in getting it to that last mile. It's a big one. And the question you also have with respect to sustainability is the state government that is expected to procure. The federal government is not involved. From the onset, we've said it. It's state that should procure. And in my presentation, I highlighted that about 19 states have been able to procure using the World Bank grant that we got at the federal level. So that's what we are. So even with the departure, I'm Rachel, Dr. Olainka, with the departure with the exit of MCSP from Kogi State, even the governor has demonstrated that political will already. He has procured about 3 million tubes. So, and I'm very sure it will be sustained since that process has come from him. So, Dr. Olainka.
I think one of the things that can help is really also around the demand side and looking at the private sector. The closest people to the community levels are what we call the patent proprietary medicine vendors, the chemists. And once we can improve their knowledge around the use of chlorhexidine, also generally improve health literacy around newborn health, I think we will see the last mile, because they are more dependent on people asking. They will not keep a product nobody is asking for. And there's a general mindset around it's a newborn product, there should be a prescription. So health promotions, pushing demand, improving health literacy will go a long way in addressing the gaps around distribution, last mile distribution. Thank you.
Thank you. Let's take a question from our online participants now. It looks like this is for any of our panelists. So we've talked a lot about resource planning and management, not just restricted to financial resources. So this question builds on that. And this person is interested to know, how did you balance focused, concerted attention on maybe one or two key interventions, whether that's chlorhexidine or something else, to ensure that the extra time and resources diverted to that focused effort doesn't detract attention away from other RMNCH interventions and approaches? Obviously, the balancing act is not an easy one. So maybe one of our Rwanda colleagues.
Okay.
For us, newborn.
Thank you. Since we implemented 2 interventions, I think I can be able to share our experience and how we did not divert the attention of government priorities. So it is about sitting with other partners and also according to government priorities that for example, Rwanda, what we do from the every year, it is just to look at what do we need, how do we need it, and how do we put on balance so that we don't divert the attention of other interventions. So for us, it is very straightforward. We always have priorities, government priorities, and we support the government according to those lines.
Yeah, I think I agree with this good point. This is what we see when the health provider receive another intervention. They say we are very overloaded, and sometimes they don't give a quality service because all intervention finally go to the health facilities. And you see even the movement during the training, meeting orientation, and it's very tough for them, but the vision for Rwanda is very clear. We would like to, by all intervention, can support country to reduce the mortality, maternal and child mortality. What we encourage the health providers is to work very closely with population on prevention and promotion, because they put more effort on curative package because the health center is supposed to generating also money. And during all mentorship, we encourage them also to prevent and to go even at a village level for some outreach activities. And last year, we found some solution. The government adds more staff through the government payroll at health facilities, like a nutritionist, like people can help on community health activities and environmental health activities. I think with this change at government level, we can manage all intervention, but very huge also to manage all intervention at the same time.
Thank you. I think a final quick comment from Dr. Ilunga.
Merci beaucoup. Dans mon pays, nous travaillons en forme d'entonnoir.
So in our country, we are working in like funnel. Sorry.
Donc, le niveau opérationnel, c'est le district sanitaire ou la zone de santé qui a un plan.
So at the very operational level, it's the zone de santé or district that has the operational plan.
Donc, même si nous qui sommes du niveau central, on veut une impulsion sur une intervention, mais le niveau de la zone de santé intègre toutes les interventions et ils respectent également leur plan.
So even if you have the central level have an agenda and priorities, they have to be included in the health zones plan and they have to manage it at the very local level.
Nous les encourageons à cette intégration et nous les appuyons à réaliser l'ensemble des interventions et ne pas seulement de faire une seule intervention à un moment.
So we encourage them to look at all of the intervention and to integrate them into their plans, but we cannot force them to look at just one single intervention that we are promoting ourselves.
Voilà un peu ce que nous faisons chez nous.
Thank you.
Merci. Bien noté. I'm afraid that's all the time that we have for this panel, but I hope you'll join me in thanking our country panelists. Thank you. And with that, we'll now invite our next group of panelists up here to join us. So while they're getting settled, just a note to say that we began today's discussions really zoomed in on experiences at the country level. So now we're going to zoom out for global perspectives on what works, but also what doesn't work for achieving sustained impact at scale. Leading us in this conversation is John Barrazo, Deputy Director of the Office of Maternal and Child Health and Nutrition with USAID's Bureau for Global Health. John, over to you.
Thanks very much, Nefra, and thanks to the MCSP team that's been doing a lot of hard work organizing for this event. It looks so easy, but it actually takes an enormous amount of preparation. And thanks also to the Wilson Center for providing this venue and this space, and for not only today, but for so many times over the years in terms of this providing a venue and a platform for open discussion. It's really great. I'd like to introduce our panel and the role of this panel. I think Nefra started to introduce it. This is the talk show host. This is the talk show format. So I'm supposed to be either, Oprah or Sean Hannity, depending upon your political persuasion. But I think we are the humble observers, people who are stakeholders in this process, facilitators in the scale-up process, supporters of the scale-up process, and this is the role is to reflect a little bit on some of the themes that have emerged. We've talked a lot about partnership and innovation, demand creation, resources, information, and so I'm going to jump right in, but first introduce our panelists. So immediately to my left is Laura Giron, who's Vice President of Partners in Expanding Health Quality and Access, and also a member of the ExpandNet Secretariat. And you might have noted that ExpandNet was one of the partners listed in the Nigeria project on chlorhexidine. Next is Larry Cooley, who's President Emeritus, which sounds very grave, but a President Emeritus and Senior Advisor for Management Systems International, who's actually the founder of MSI in 1981. And he's also a recognized expert in change management. And then finally, Steve Hodgins, who is Associate Professor at the University of Alberta, and he's Editor-in-Chief of Global Health Science and Practice. And he was formerly here with us in Washington, D.C., working for Save the Children, but both for MCHIP and Saving Newborn Lives, and decided to decamp to the far north, where he told me the snow just melted 2 weeks ago. And you've already been introduced to Jim Ricca, who kicked off this event. He's going to be available as part of this panel to answer questions that we'll pose as well as questions from the floor. Just a clarification, are we stopping at 11 or are we going? Okay, great. So I just wanted to sense of how much time we have. So first, let's start by saying, having heard all these excellent examples of country scale-up, of maternal, newborn, and child health interventions, and drawing from those experiences as well as your own experiences looking at these issues more broadly, what do you see as the critical success factors for reaching sustained impact at scale for these MNCH interventions? And we'll just take it in order and come back to Jim at the end. Please, Laura.
Great, thank you. Well, one of the things that was so exciting, I think, about the Maternal and Child Survival Program was its effort to be very explicitly focused on scaling up. And one of the things that we've learned and expanded over the years is that one can approach scaling up in a very ad hoc way, or one can do so more systematically. And you heard examples from Nigeria, DRC, and Rwanda where the team was focused on some key critical issues that we know are the determinants of scaling up success. And they relate to a focus on monitoring and evaluation, where you heard examples where each of the countries sought to embed their innovation in the health management information system. One also needs to focus on resource mobilization, and we heard very creative ways that DRC was able to bring together several donors in support of ICCM. And another one was to think about how to systematically approach training and capacity building to implement the intervention package. And we heard some good examples about how that was accomplished. So these are just some key examples about how one can approach scaling up systematically. And there is guidance out there from Expanded and Management Systems International and others who are trying to make this learning accessible to different kinds of audiences who can use that information to enhance the way that they approach the scaling up task.
I'd add on to that the fact that I think these are three cases that really illustrate in an incredibly poignant way how important country leadership really is on this. Because when you come at this sort of problem from the perspective of a project, it's almost impossible not to go too vertical. It's almost impossible not to try to get around the country constraints by creating something that runs in parallel to that. It's almost impossible not to take a 3 or 5 year perspective rather than a 17-year perspective on this. The only antidote I know to that is the country really taking the lead. So it's not just a philosophical proposition. It's a very practical proposition for what you need to do if you're moving this thing forward. And the countries that are most, I'll use the word aggressive, in doing this, I think have done the best job in terms of trying to really take things to scale in an important way. The two things that kind of follow from that. One is that there really, if you think about it, there are really only two platforms that can deliver results sustainably at scale. That's governments and markets. So unless you have a strategy that's going to permanently influence one or the other or both of those, you don't have a scaling strategy. So we talked mostly in these conversations today about the government side, but think hard about each one of the cases. There's a commercial element to it too. And it's somewhere along the supply chain that delivers this result. And the incentives are different, the organizational structure is different, and again, because the outcome is only as good as the weakest link, unless you can find a way to bring those things together, you fall down on one side or on the other of that. I think we saw good examples of really trying to thread that needle, but it's not an easy needle to thread. And the last thing I would say, still on this theme of country ownership, is that it's very hard to get someone to scale someone else's idea, no matter how good the idea is. And so unless the people who are supposed to be delivering this at scale are really deeply embedded partners, in fact, leading from the beginning, the chances that bridge that's supposed to span the two platforms is much shakier than we think it is. We think if we can just do proof of concept, all of a sudden this thing's going to walk across the bridge to the other side. In my experiences, that's not so.
Steve?
Yeah, great. I mean, I think we've had quite rich presentations and the discussion that followed. One point that was made in one of the presentations is that one cap does not fit all. And so as a consequence, it's important to understand the scale-up environment where you're introducing your intervention. I think this is a really important point. So we need to be developing plans that are responsive to the particular context that we're in. So the strategies need to work like not in somebody else's setting. They need to be strategies that work on our own. That having been said, regardless how much homework we've done or how good a job we've done in developing our plans, no battle plan survives contact with the enemy fully intact. Okay, and I think that came out quite clearly more in the discussion than in the presentations. In the discussion, we were hearing from the various groups about kind of issues that had come up in the course of them trying to implement their interventions that hadn't been anticipated at the time that the plans were developed. I like to think of there being kind of broadly two categories of, say, learning and adaptation. There's single loop learning, where we're looking at kind of operational details, and we had some examples of that, for example, with commodity. So you find that you've got commodity sitting in your warehouse or you're in the stores, and it's not moving to the providers, or it's in the health facilities and the providers aren't using it, or you've got interruptions in your supply chain. So one of the ways that we use data is we monitor for performance of those kind of operational issues, and then as and when needed, then we take action. The double loop learning and adaptation is more learning and adaptation where we may need to change our strategy altogether. I think in the case of Rwanda, there was a bit of discussion about HBB. So in the early years, I mean, there was purchase of some bags and masks, there was some training that happened, but the asphyxia-related mortality wasn't dropping. And so there was I think a causal model in mind that, if you've got the equipment there and if you've given the training, well, then everything is going to happen correctly and we're going to save those babies. And that turned out not to be the case. So it was necessary to step back and re-examine assumptions. And so finally, the conclusion was that, well, people have got to practice regularly. So there's this idea of this low dose, high frequency. So there was a new strategy. So some of those initial assumptions had to be questioned, and a new strategy had to be developed. So that's what I think of as double loop learning and adaptation.
Jim, having heard that and having heard the presentations, are there you provided the opening framing. Is there anything you'd like to re-emphasize in terms of things that are critical success factors?
Yeah, thanks, John. Just a little bit. First, we'd like to thank ExpandNet, who's helped us indirectly, across all these examples and others as well in Liberia, Afghanistan, Bangladesh, and several others where we're supporting scale up. But I just kind of want to emphasize maybe a couple of points I heard from others as well. This idea of buy-in, a lot of times I hear this word thrown out a lot, but I think Larry kind of said, things have to start from the beginning. You don't want to buy somebody else's intervention. So I think co-design should be the operative word. Whoever is going to be in the thing, whoever is going to be taking over needs to be co-designing the process rather than buying somebody else's intervention, something of that nature. I think also the idea of trial and error, I think, is kind of really got to be embedded in things. We talk about adaptation, we talk about learning, talk about data use, but at base, we're really talking about trial and error. I really congratulate Rwanda, like Steve said, for kind of having scaled up once this idea of saving asphyxiated babies and realizing it really didn't work that well, and then doing it all over again, but doing it with the lessons learned and really doing it a different way the next time. I think last thing I want to say is when a lot of people kind of throw around the idea of data use, super important, but then it's not just the data, obviously, it's the use itself. And I think a couple of things that are kind of out there now that really facilitate this. One is DHIS2. It allows us to package things, it allows us to present things, it allows us to curate the data in a way that doesn't mean there have to be a lot of parallel data systems, et cetera, but it's really in a presentable manner that is more intuitively obvious what one does with it. That's one thing, but the data is only as good as what goes in. If it's garbage in, it's garbage out too. And I see a lot of people, get data in front of them and say, yeah, it doesn't look like a good result, but it's junk anyway. Let's move on to the next thing. If people really aren't going to trust their data, then it really isn't going to kind of have any use. But rather than short-circuiting the system, if there are there's more attention focused on proving data quality and really sticking with it and getting people to use that data, I think that's very important.
Okay, thanks. It's all actually 3 points that actually lead into the next question in some ways. So we've got this idea of trial and error. We've got this idea that the battle plan has to change. We've got these ideas that there are both markets and there's public sector, and one or both has to take a leadership role. But you know what? And for USAID, I think for all of us who are trying to roll out maternal, newborn, child health interventions, increasingly we're finding ourselves in fragile settings. And some of those fragile settings, some of those elements are not necessarily going to be in place. And so when we think about those fragile settings, whether it's fragility from insecurity or from violence or potentially lack of transparency or just other stressors, what are some of the things that have to be thought about differently in making progress and moving to scale in those more fragile settings? So I think we'll start with Larry on this one and then move around.
Well, a colleague of mine named Jonathan Papalidis and I recently wrote a paper about scaling up in fragile states. And it was for me, a very instructive process to stand back from the scaling situation in general and say what makes that circumstance different. And I would say if some of the things that you've been hearing today are about the importance of context, my sort of tagline on that is context is king. If you move into these fragile states, context is emperor. I mean, you take everything that was already true about context and you put it on steroids. And it's got a few different pieces of elements that follow from that. The first is that the two platforms that I was talking about before, governments and markets, they're both compromised, both of them. And so when you see the interesting cases, and I could, if we had time, share with you several interesting cases of scaling in fragile states, they found very clever workarounds that somehow compensated for and built redundancy into the fragile situation with government and the circumstance with markets. The second thing is that people will see whatever you do through the lens of the underlying grievances. You think it's a health intervention, but it's not just a health intervention. People are going to see it in terms of the government's preference for one group or another, or if there's somebody other than the government delivering the service, they'll see it as a statement about the inability of the government to do that. So the perspective that needs to be brought to bear on the delivery is not just a chance to avoid harm, which you easily can do, but also a chance to really advance some of the some of the building blocks of peace or stability in this. And a lot of the resilience discussion, the best of it, really tries to take hold of it this way. How do our interventions provide an opportunity to really work at some of the core drivers of instability or lack of resilience? And the third point about fragile states is that resources tend to flow in very quickly around a crisis, and they flow out equally quickly. So the problem you heard before about we had partners in such and such a place, and then when the time came, we didn't anymore. That's especially true in fragile states. So the planning, the financial trajectory becomes something you have to give a lot of extra attention to. And finally, you have this whole notion that the ability or the likelihood of shocks and stressors go way up. It's almost a given that the plan you have or the circumstance you inherit will not be consistent throughout. So the ability to build into it the level of adaptation, which everybody in the donor community now talks about, but very few of us do, I think becomes especially paramount there.
Laura.
Sure, gladly. So one of the things that we really believe about scaling up is that it's critical that whatever innovation you're testing or intervention you seek to scale up, you have to think of it as part of a systems perspective. You need to take a systems thinking approach. And whenever you're scaling up in a system, you should be endeavoring to try to strengthen the system more generally so that it can accommodate and institutionalize your intervention package. And if, for example, you've tested something that you then want to scale up, you have to be examined about what you actually did in terms of that intervention package to know, well, in fact, we did actually do some system strengthening, and consider that as part and parcel of the whole package that needs to be scaled up, because otherwise you're going to meet with failure along the way. And one other key lesson that we have is that always, even within fragile systems, there are people and points of strength that can be built upon. For example, there are those who know the limitations of the system, but are trying, endeavoring to work around them is a nice word, or to think about how to capitalize on those strengths and really push them forward.
Do you mind if I sandwich in one more point? Sorry, Steve. So we did a series of evaluations of vertical health funds in Ghana and in Sierra Leone, 2 adjacent countries. As luck would have it, there were about 30 of these vertical health funds in each country, and in many cases, precisely the same vertical health funds. When you looked at the situation in Ghana, the net add was really obvious. When you looked at the same situation in Sierra Leone, it was a disaster. I mean, it was really horrible. How do you explain the difference? Same vertical programs, 2 adjacent countries, and so on. My explanation is that Ghana had an underlying public health system. So they were able to take from each of these things the things they needed, and the country could do the integration. They didn't depend on the vertical programs to do their own integration. In the case of Sierra Leone, it was exactly the opposite. So what you did was completely balkanize whatever health care there was in the country. The net effect is maybe you scaled up some things, but in the course of doing so, you did tremendous damage to the underlying system. So for me, one of the real issues of fragile states is who's available to do the coordination, and how do you build that in a way that makes sure these things are additive?
Steve, any changes to the battle plan?
Yeah, just very briefly, when we do scale-up work, our tendency, I think, is to focus a little bit too exclusively on the intervention and characteristics of the intervention. And as we've been discussing just now, we need to be giving appropriate attention to the system that's going to have to deliver that intervention, and pay attention to characteristics of that system. Sometimes the interventions that we're introducing, like, they make relatively heavy demands, and we need to make a determination whether that's realistic given the system that we actually have to work with. And sometimes it's not. Sometimes, an intervention that may seem inherently simple may in fact be quite demanding. That's okay, providing we've got a system that's sufficiently robust to deliver it. But again, we need to be paying attention to both sides: the characteristics of the intervention, and then the characteristics of the system that we expect to see delivering it.
So we talked very briefly about this issue of financial resources, but let's talk a little bit more about it. How important do we think that a lack of financial resources is to successful, sustained scale-up? And specifically, this issue of the role of external support agencies, aid agencies like USAID, and how can we ensure that we actually do no harms? I'm going to start with Larry, because I know you're passionate about this topic. And why don't we start there, and then we'll move on to others. Thanks.
Well, I'm going to make the case for why it's very important to focus on the financial resources, and I bet others are going to make the case as to why that's not sufficient. So I'm going to stick on the financial resources question. And you remember when, in the DRC presentation, that graphic went up that showed that 7% of the funding was coming from the government itself? And not everyone, but a number of you applauded at that point, and so did I. But you could read it the other way and say 93% of the resources were coming from somewhere else. And you ask yourself over time, what fills in that 93%? And there's a tendency in this kind of world to focus on the introduction phase of something and not necessarily on the continuation phase. And the budgets, I would encourage you to think of these as 2 separate things. What's the funding necessary to get something on stream, and what's the funding necessary to sustain it over time? Ironically, we used to do better on this issue in the old days when we talked about the recurrent costs of things, and that's kind of dropped out of the vocabulary a little bit. And so the notion of what it really takes to sustain something over time doesn't get the attention I think it really requires. If things are going to go on budget, remember some of the things in health that we're moving forward, we're doing more with more, because donor resources have been on the increase for a long time in this arena. Eventually, that's not the case. So either they're going to have to be alternative sources, or we're going to have to fully absorb these things on budget in the countries where they operate. And that graph that Jim had up about the growing role of public funding, domestic public funding of healthcare, is going to have to play a prominent role, as will private activities, the private sector portion of this thing. So I think, to me, this is an enormous part of the conversation. When we're asking people to take something on, be very, very, very clear what the medium-term consequences are in terms of getting this on stream, but equally clear about what it's going to take to sustain that as an additive part of the public health care or the healthcare system.
Okay, thanks, Laura. Steve? Nope, pass. Laura?
Yes, thank you. I thought you might talk about the role of projects, Larry, because projects have an important role, and yet they also have a tendency to complicate matters in the sense that people who are intervening at the project level often want their project to be scaled up and will do everything within their power, but that may detract from other aspects of the system. So one of the things that we argue about scaling up is that it's very important to have a scaling up focus, right? In other words, if you approach your scaling up task with the system's perspective and with the idea that you're trying to build the system to implement rather than the project themselves to do the implementation, then you're more likely to have an intervention that's going to be better institutionalized and more capacity within the system to implement it. So one of the things that I would say in response to that question is that one does need technical resources in addition to financial resources, and of a specific kind. Technical resources that, technical support personnel or people within the system who have the technical capacity to lead scaling up effectively. And as I started my remarks today, I was saying there are ad hoc ways and there are systematic ways. And so those who've sort of internalized a systematic approach to scale up are likely to have better success over the longer haul.
Could I interject a quick piece of data here, maybe?
You absolutely can, Jim.
Am I allowed? One country that MCSP was supporting recently, someone got back and said that there was data showing that funds available at the district level for health programming were only being 20% used. So there were funds out there that just weren't getting programmed. We don't want to distort things and kind of pull them all toward, this one scale-up effort. But on the other hand, kind of just being able to curate and shepherd and help plan for the resources that are already available certainly is, would be a value add.
Okay, thanks. So we're actually, because we're running a little bit late, we may not get to some of the other points we had discussed, but maybe we can bring them out still as part of the audience Q&A. So we're going to turn to the audience now, to all of you in various places. And just to quickly reiterate Nefra's remarks, make it a question, not a statement. Be succinct, introduce yourself, and if appropriate, direct it to a particular panelist. So any questions from the room, please.
Well, thank you all so much. That was a good discussion. My question is specific to Dr. Stephen Hodgins. Do you mind reiterating the double loop piece you talked about? I just need to be clear about that. Thank you.
Okay. This language comes from Chris Argyris. I didn't originate it. But the idea is that like a thermostat is kind of like a single loop learning system. Okay, so it's set so that at a certain temperature that triggers turning on the heat or turning on the AC. Double loop learning and adaptation implies that there's some, you're stepping back from what you're doing and you're looking more strategically at what your initial assumptions were, what your initial strategic design choices were, and as necessary, you might need to change direction. In either case, like it's the action or the adjustment or the adaptation that's key. Like to learn, it only produces some benefit in the real world if you take appropriate action.
Can we follow up on that in terms of the learning piece? Because we had some interesting discussions as part of our pre-discussions for this. When do we know, since stakeholders can have a tendency to become over-invested in the success of something they've decided has to be successful, how do we know when we actually should take a pause and look at the evidence and learn something and make a change? How do we know?
Yeah, this is a hard one. I think the point is certainly well taken that we fall in love with our babies. And so it can be very difficult if you're the innovator or the champion for some intervention, to recognize that somehow things aren't going. I think this was an issue with HBB. So there was this very nice 2-day training package, this wonderful neonatally, one of the babies I've fallen in love with. But that turned out not to be enough. So just to give but the people who were promoting it, I think, were very invested, and there were certain features of that package that they were very appealing. But I mean, in the end, I think one of the things that turned things around is as people were actually implementing this and they were paying attention, well, what's happening with our mortality rates? And, you know, are babies actually getting resuscitated? So there's this reality check. So I think those that are on the front line, those that are implementing, those that are operationalizing these plans are the ones that are best placed to see, is this really working as we expected it to or not? And then we got to bring sometimes this unwelcome news to the promoters, and you know, so that, and then I think that can trigger us to step back a bit and re-examine our assumptions and strategy.
Anybody else have any comments? Or?
Yeah, I would add to that well, so Expanda has developed a 9-step approach for developing a scaling up strategy, and in such an intervention where the implementers say that we have a proven package and this works, the first step of that process is really to reflect on that more carefully, and ideally to do so with a larger group of stakeholders, like Steve is saying, and what was really done with the chlorhexidine example in Nigeria, where a large group of stakeholders were involved in developing that scaling up strategy and articulated what they felt was needed in order for scale up to be successful. And you know, once you have those different voices and different points of view on the issue, you're likely to perhaps have some disagreement or really try to reach some clarity on what's the most realistic and appropriate way to proceed. But it's precisely doing that analysis, and in step 1 of the 9-step approach, sometimes you reach the conclusion that in fact this baby should not be scaled up. This is not really going to be able to function properly within the larger system. And then one needs to deal with that.
I'll add one piece onto the end of that one, which is that there's a strange psychological dynamic to this I've seen, because in order for people to really lay the foundations for scale, they need to begin early on to act as if the thing were going to be scaled. They need to enroll people in it. They need to try and build the foundations that you would need for scaling. And that's often before the evidence will support scale. If, on the other hand, you wait until the evidence is rock solid, you haven't done the things that you need to do to create the foundation. So you're asking people to have one foot on the accelerator and the other foot on the brake. It's a very difficult thing to do. And it's the reason why I think what Steve implied about having some third parties that are looking in on this becomes very important, because you wouldn't want to try to keep people entirely skeptical about the thing you're asking them to be committed to. At the same time, you would not want to presume an answer to something that's exactly the question.
I'd like to jump in quickly. I see Joseph Petralia at the back, who has taught me an important lesson about adaptation. I think it's really the case that probably 5 years from now, whatever interventions we're talking about will not be the same things as what we're talking about now. It's really not a yes or no question. Does the intervention work or doesn't it? It's going to change with time. It's going to change in places that you are in different places, even within a country. And I think having that ability to kind of have a trial and error mentality is really important. There needs to be a plan. I mean, it's not just kind of out there doing whatever. There is an awful lot of talk about fidelity of an intervention. You know, I think we need to minimize the amount that's fidelity. For instance, if health providers or mothers in Nigeria are not applying chlorhexidine to the umbilical stump in one way, then they're not really doing the intervention. But everything else is on the table, right? In terms of how you get it out there and how you're going to make it work. And, you know, it needs to be kind of adapted, et cetera, as you go.
Okay. We have a question from Twitter. Okay. Okay, so here's the question. I'll just read it verbatim. In order to have country-led scale-up often requires patience. So how do projects do, quote, the right thing even when donors demand rapid results? And I'm actually going to let Larry start on that, because it contains a couple of buzzwords there that I think might trigger some response.
Well, we had a very agitated conversation about this yesterday. And I think you could easily interpret what I'm about to say as being more donor critical than even I want to be. But I do want to, I do want to make a point on this, which is that if you think about this from the point of view of the country, if you think about the services we're talking about, There's a world before the project, there's a world after the project. The project is a short-term intervention trying to change that trajectory. But if you think about it as the donor, it's tempting to think about the project as the thing. And if you become so narrowly focused on the project, then the intervention, for example, is a series of projects end to end, as opposed to simply the project as a way of adjusting a trajectory. So I think to the extent we as donors have inadvertently not only adopted that perspective, but transferred that thinking to the governments, we've done them a disservice. Now, does that mean you can't use projects to try and affect underlying systems? Of course not. And you heard some really terrific examples today of exactly that. But I do think it's a danger that's built into the system. And the questioner, I think, is right to point us in that direction. So if we're serious about this country-led thing, it really does require something like, as a minimum, co-design of the sort that Jim was talking about, or even in some cases we the donor, are the trailing partner in this, and that's not entirely comfortable. The other thing that happens is, building on the point that was made about adaptation is so easy to say and so hard to do, because you have to give someone the discretion to interpret the data and make the change. And when you're talking about publicly funded programs, that's got a con as well as a pro to it, in the sense that people, if you give them discretion, they won't always do what you want them to do. In the best case, of course, they learn the lesson, they make a wonderful change that wouldn't have happened otherwise. But what if they either do this for self-benefit, or they do this simply ill-advised on this? What's the control on that? So we've now gone so far in the direction of creating those controls in a kind of a no-fault mentality that it becomes very difficult to retain the flexibility in the adaptive dimension that I think everyone conceptually thinks is important to success.
Yeah, thanks, Laura. That's we take that to heart. Okay, any other comments, Steve, Laura? No? Okay, so we've time for another question from the floor, please, and don't forget to identify yourself.
Thanks. Hi. Great panel. My name's Carolyn Hart with JSI. And I was actually going to ask this question to the last panel, and I didn't get my chance, so I'm going to throw it to you all. What have you seen as the contributions or the potential contributions from sectors outside of health to a scaling up? Our colleagues from Rwanda mentioned, it was DRC, mentioned the inclusion of the Ministry of Planning, the Ministry of the Interior, the Ministry of Health, and maybe another one. So sort of the multi-sectoral thrust that can be achieved outside of health for a health intervention. Thanks.
You want to start?
Yeah, I was so appreciative of the DRC example, bringing to the table the planning, interior, health, and I forget who, the finance. What a brilliant collaboration. And in fact, it's one that we often are advocating for and scaling up, but it's actually really hard to achieve. But when you do, you really see that in DRC they were incredibly successful, because what happens in health is that people often feel hamstrung that they can't accomplish things because the funds aren't there. And that's another thing we were talking about beforehand, is that the funds often aren't there to innovate within public sector programs. But when one has as a partner from the very beginning the Ministry of Planning and the Ministry of Finance, and they can garner an appreciation for the need for this intervention and how it will address a third to half of the mortality impact that we want to achieve, really we have a much better chance of moving ahead in lockstep and having the funds available. So thank you for raising that. I also wanted to invoke that example.
I want to take a different dimension of your question. I'm not sure if you were implying this or not, but I curate a global community of practice on scaling. And the whole premise of that was bringing together different sectors to talk about scaling. So we've got a large agriculture and rural development working group, a health group, an education group. We've got another group on fragile states, one on monitoring and evaluation. And I've been really struck by the benefits of cross-learning around that sort of thing, in areas I would have guessed, in areas I wouldn't have guessed. For example, I think the agriculture folks have really taught the rest of us some things about the role of the commercial part of the pathways on this. The education people, because that's the most government-centric of all the sectors, have taught us quite a bit about the process of policy change and trying to influence government decisions on this. The health people started out furthest ahead because of ExpandNet and other things in terms of just thinking about scaling systematically on this. So I think they taught everybody something about that, and also have the benefit of somewhat more tangible outcomes than some of the other sectors have. So the conversation is really rich, and it's most rich when people are talking across those divides, not just within them.
Maybe just one follow-up point. And this, I think, came up from the DRC discussion. I mean, as I understand it, like at least part of what triggered this was there was GFF kind of funding potentially coming into the country, and so necessarily there needed to be decision makers, beyond just the Ministry of Health. A lot of the interventions that we tend to pay attention to on the technical assistance side are delivered through primary healthcare system or at community level, and different countries have different degrees of development of that primary healthcare system. I was recently talking with some colleagues from Mozambique, where a few years back they started to put in place a new community health worker program, but it's very thin on the ground. And up until now, like, the government isn't providing the funding to compensate them. But a decision to actually create a more robust tier in the system, that's something, I mean, the Ministry of Health can have a wish list, but the Ministry of Health by itself can't have significant new resources committed to build a tier in the system. So that requires involvement from a planning commission, Ministry of Finance. So I think inevitably, again, thinking about the interventions and then the systems needed to deliver them, effective scale up may depend on making the system more robust than it currently is, and then that may require decision making outside of the Ministry of Health.
Okay. I think we have time for one more question if we can keep the answer short. Any other questions? Okay, back.
We have seen many very interesting programs.
You are?
I am Taye from the American College of Obstetricians and Gynecologists. We have seen a lot of very interesting programs falling off the cliff just when the funding stops.
Right.
Shouldn't organizations like USAID and the other major funders associate the donation of the funding itself initially with a matching local contribution?
So is that a question for me? No, this is the
I think so.
I'll start the answer, but then others will jump in. Certainly, I think this idea of that we are partners in development with country programs is part of our bilateral conversation. And certainly looking at how do we build in sustainability from the start is a critical part of what now is being called by the new USAID administrator, Mark Green, the journey to self-reliance. So I think this is very fundamental. It's not an entirely new idea, but certainly it's at the center of what we're trying to articulate in every one of our country development strategies looking forward. So I think that the premise of your question is actually forming the basis for the way we're trying to increasingly make sure that we operate. Granted, there's going to be a lot of variability in terms of the way we operate given fragile settings, urgent need, critical humanitarian situations. But in terms of what we're trying to do in terms of our overall development trajectory, I think that figuring out the ways to have that transition to sustainable sources of financing is a critical part of successful development. So but I'll let the others chime in.
I think another key learning about scaling up is that it's not the same as routine program implementation. And the routine program is not necessarily ready to adopt and absorb a new intervention package automatically just because someone has proven that it works within the system. And this is interesting concept, the journey to self-reliance. In Jim's opening remarks, he showed how a higher and higher percentage of the global health or national health budgets are comprised of the public sector contribution, which is great, but we're not there yet. I mean, it's certainly not 100%. And even if it was 100%, I'm arguing that with scaling up, you need some additional infusion of funds to institutionalize the intervention within the routine program system so that eventually it can be implemented in an ongoing way. And yet, one also must make sure that even once it's part of the system, that it's still being implemented in a steady state kind of way. So these are all matters that one has to take into consideration and attend to and keep your eye on as part of the whole scaling up process.
Any other comments? Okay, so then we were wrapping up our panel, and we're wrapping up this session this morning, and I'm pleased to, for the wrap-up, I'm pleased to introduce Koki Agarwal, who's the project director for MCSP and is from project to project, a long-standing partner of USAID and thought leader with us. So thanks, Koki.
Wow, it's been an amazing morning, wouldn't you say that? So I'd like you all to clap another round of applause for the panels, both the panels, our moderators, and our translator. And most of all for the audience who is either with us in this room or in the other room or somewhere out in the space. I also wanted to thank the Wilson Center for this wonderful partnership, for being able to host this event over here. So in Jim Shelton's, those of you who don't know Jim Shelton, he always used to come up with pearls at the end of a session. And in his tradition, I wanted to come up with the pearls. But I think I've learned so much at this session that I might just make myself a necklace. But I'm going to, because we have a short time, I think maybe not even a bracelet, I'll stick to earrings. So I think what I wanted to highlight, my first point, that from start to finish, it seems like the path to scale is never a straight path. But I think and what they highlighted was that, beginning with the policy or development of a plan or incorporating the intervention into a plan could just be the starting point. And then after that, it takes a lot of time, effort, and perseverance. And it needs adaptation. And even though you might have stresses along the way, if you have an adapted learning approach, that you can make things work. I think the second thing I wanted to highlight is that there's no silver bullet. And the experts and the country examples highlighted that institutionalizing the process and dealing with the systems issues is absolutely critical to achieving effective scale. These systems would include like building capacity of human resources, it would include resources, commodities, addressing the health information systems, and most of all, the leadership from the government. I think without that, we will not achieve any efforts at scale, especially going project to project. Another aspect I think that I wanted to highlight is that empty scale is not worth it. If scale without quality, addressing quality, is not really worthwhile because we are not achieving our ultimate end goal. And I think the other points that they highlighted, that an ad hoc approach may not be worth it. Maybe we really do need to take a systematic approach to scaling up a new intervention. And with that, it's a systematic approach and a systems-oriented approach. I think our communications team had a head up, because if you see the back of that scale-up success, it's all connecting the dots. And I wanted to highlight that as my another pearl, because I think it takes connecting the dots with multiple stakeholders, multiple sectors, at multiple levels, global, national, subnational, and bringing all of these together to address the critical issues of supply, demand, and implementation and resources. So I think connecting the dots at all levels with multiple groups is critical. But I want to leave, the pearls that I've mentioned up till now seem to be like overly difficult to achieve. But I really want to leave us with a positive feeling. And the last issue that I wanted to say, that I think our country teams have demonstrated that where there's a will, there's a way. And the country example shows very clearly that they can, and they are, and they will achieve effective scale-up for the interventions and their journeys where they've started. So I think that they've taken an approach that is systematic, that is addressing the systems, that is institutionalizing the change that they want to see happen, and most of all, it's country-led. So thank you all for coming. I think it's been a great morning, a really impressive learning for all of us. And I really wanted to appreciate the panels and the moderators and the team again. Thank you.
Thank you.